Good morning. This morning I am going to talk about pelvic ring injuries. This can occur either it's a low energy injury which occurs in elderly people, mostly osteoporotic, sustained by fall from a low height, maybe standing height. They get fractures of the pubic rami or ischial rami and displaced fractures. They are not of a big problem. They just need about 3 to 4 weeks of rest in bed. They get a satisfactory healing along with the management of calcium, addition of calcium and vitamin D. But we are more concerned about the high energy injuries whose incidence is rapidly rising because of motor vehicle accidents, either a crash or a pedestrian hit by a automobile, or maybe fall from a height, such as maybe 2 to 3 story building, and run over accidents. These high energy injuries, if not treated properly by the management of shock, then about 50% of them die on the road. In modern times, in modern places, the ambulance reaches the accident site and starts doing the resuscitation, at least IV fluids, oxygenations and others, immobilization right at the spot. Then the patient is transferred to a level 1 trauma center for a definitive management. It all depends on recently various operative treatments have come up with internal fixation or external fixation of this pelvic ring fractures. The principle depends on the stability of the pelvic ring. Stability defined as ability to support physiologic load, that is, physiologic load may be sitting, side lying or standing as dictated by the patient needs. That means when the patient in a post-traumatic scenario, when the patient is sitting or side lying or standing, there is no further displacement of the fractures. If you take a look at the pelvis, the schematic diagram, center of gravity lies in front of S2 and it comes from here, sacrum. These are ilium, these are pubic rami, ischial rami, and the symphysis pubis. The line of weight bearing goes like this from the posterior superior angle of the acetabulum, then to the femoral head, then comes medially like this. So this is the ring of pelvis. The posterior ring integrity, this is the posterior ring. Integrity is important in transferring load of the torso, that is the upper part of the body, to lower extremities. It consists of 2 joints, 2 sacroiliac joints. These are very, very important, and the ilium and the sacrum. Loss of posterior ring integrity often leads to instability. Loss of anterior ring integrity may contribute to instability and may be a marker to posterior ring injury. It's obvious that if there has to be a gross displacement here, either symphysis pubis or the superior pubic rami or the ischial, if there has to be a gross displacement here, there has to be some disruption in the sacroiliac joint or sacrum. Otherwise, this cannot happen. Tile classification scheme based on Mervyn Tile, he classified the fracture pelvis based on the instability patterns. Is there deformity? Yes, there is a deformity here. The symphysis pubis is widely separated, symphysial disruption. So, if you look carefully here, there is some disruption at the sacroiliac joint. The gross discrepancy here, gross displacement here always denotes there is some displacement here. So, deformity on presentation predicts instability. Look, is there deformity? Is the posterior pelvic ring intact? I mean, this posterior ring is not very well visualized by traditional X-rays, for which to have a clear look at the posterior structures, one need to go for a CT scan. This is a CT scan view of the pelvis. Here you can see there is disruption of the this is a normal sacroiliac joint and this is a displaced sacroiliac joint. If there is some displacement here, this one, then there has to be some disruption here. Is there deformity? Is the posterior pelvic ring intact? There are stress radiographs. I mean, if you look, this fracture of the superior pubic ramus looks innocuous. There is not very grossly displaced, but if you put stress on this, if you put pressure on the ilium and the anterior subiliac spine and try to move the pelvis apart, open book like this, then you can see there is gross displacement occurring. So, this is a potentially unstable injury which is revealed by a stress radiographs. These are stress radiographs. Here, is there deformity? Is the posterior pelvic ring intact? Stress radiographs. Are there clues to soft tissue injury? There are very important soft tissue injuries in pelvis. In X-rays, you get indirect evidence. You cannot see a ligament here. If you want to see ligament, then you will have to go for MRI. If there is L5 transverse process fractures here, if there is L5 transverse process fractures here, if there is ischial spine avulsion, which can be seen here, ischial spine, or if there is a lateral sacral avulsion, then these are evidence, indirect evidence of instability. So, this can be treated by two ways, either it's a non-operative management or a operative management. Non-operative management consists of, non-operative management is mostly for those lateral impaction type injuries with minimal displacement. Where there is less than 1.5 centimeter displacement, one can go for a non-operative management. Pubic rami fractures with no posterior displacement, minimal gap of pubic symphysis without associated sacroiliac injury, 2.5 centimeter or less, assuming no motion with stress or mobilization, that can be assessed by stress radiographs. This number is not absolute, so other evidence of instability like sacroiliac injury must be ruled out. X-rays are static picture of dynamic situation. It may be that the deformity is worse than seen on X-rays taken, because in some cases, initially at the time of the injury, there were displacements which spontaneously became somewhat reduced by the posture of the body. That is possible. To find those out, you need to go for a stress radiography. Post-mobilization radiographs should be taken in all cases of non-operative treatment. Suppose after 6 weeks, you take post-mobilization radiographs to see the position, whether it has displaced during the treatment or not. Other evidence of instability should be sought, that is lumbar transverse process fractures, avulsions of sacrotuberous or sacrospinous ligaments. Non-operative treatment, tile A, stable injuries can generally bear weight as tolerated. Walker, crutches or cane often helpful in early mobilization, because many of them are elderly, so one should encourage early mobilization. If they lie down for a prolonged period in bed, that will lead to further disuse osteoporosis. Serial radiographs followed during healing. Displacement requires reassessment of stability and consideration given to operative treatment. What about the partially stable tile B injuries? Can be treated non-operatively if deformity is minimal. Weight bearing should be restricted, that is toe touch only on side of posterior ring injury. Serial radiographs followed during healing. Displacement requires reassessment of stability and consideration given to operative treatment. Failure of non-operative treatment may be due to displacement after mobilization. Excessive pain which precludes early mobilization may also be failure of non-operative treatment. Principle of operative treatment. When we operate, posterior ring structure is important, that is to be revealed by CT scan. Goal is restoration of anatomy and enough stability to maintain reduction during healing. Most injuries involve multiple sites of injury, that is both anterior and posterior. In general, more points of fixation leads to greater stability. This does not mean that all sites of injury need fixation. The important sites are fixed, that leads to perfect healing for the other injuries also. Anterior ring fixation may provide structural protection of posterior fixation. If combined open and percutaneous techniques are used, the open portion is often done first to aid in reduction of the percutaneously treated injury. Maybe the anterior technique is done first, then if necessary the posterior fixation is done. Preoperative planning. The patient-related factors, that is surgical clearance, that is anesthetic clearance, resuscitation, if the patient has completely come out of shock, hemorrhagic shock. Coordination of care, there may be some other associated injury to internal organs also. So one should take the help of a trauma surgeon, intensivist and the neurosurgeon. Suppose this is a injury. Here you can see the amount of ecchymosis, the severity of the injury. This is another injury, there is blood collection here also, the severe trauma here and at the perineum here. So may need general surgeon, genitourinary surgeon, gynecologist and the plastic surgeon. Timing of surgery. Reduction may be easiest in first 24 to 48 hours, but The patients often are not adequately resuscitated in first 24 hours because of the massive amount of blood loss in these fractured pelvis. The pelvis is mostly composed of cancellous bone. They bleed a lot. So that blood loss has to be made up by blood transfusions. Then only one can operate. When this hemodynamic status is stable, that is the only time one can operate. And there is potential for surgical secondary hit, that is a secondary inflammatory reaction on post-injury days 2 to 5. This could be a significant issue in open procedures. In open injuries, it should be tackled immediately. Intraoperative imaging is required, so you should have a radiolucent table, fluoroscopy, that is C-arm. Radiologic technician and surgeon understand the C-arm views necessary. How to reduce those fractures? Either it's by traction. We have special orthopedic tables by which traction can be applied. There can be pelvic manipulators, that is femoral distractor, and there are specialized clamps, bone holding clamps, by which helps in reduction. Implants needed extra long screws, cannulated screws, often extra long with appropriate instruments, specialized plates for contourability. The pelvis has a peculiar shape, so that the plates, these are called reconstruction plates, which can be contoured easily, or external fixation. The surgical approaches are planned, that depends on the traumatic, the structures which are traumatized. Soft tissues are examined. Patient positioning is planned. Is it safe to prone patient? The anesthetist should share this. Equipment on padding for safe prone positioning. This is anterior approach. Here is a fracture. This is called a fan and steel approach. That was a very popular approach when people used to operate on the prostate glands during the days of open prostatectomy. Nowadays, large majority, almost all of them are done by transurethral resections by a cystoscope. So, exposure of symphysis pubis and pubic bones. Then the fracture is reduced and a plate is applied. There is another Stopa approach, exposes symphysis to SI joint along pelvic brim. This fracture is exposed. Now it's put back into place and plates are applied like this, plates are applied like this. There are posterior approaches also for the sacroiliac joint. There, after reduction, plates are applied. Surgical approaches, posterior pelvic ring. This is the approach, sacroiliac joint. This could be a incision line, sacroiliac joint. This is ilium and the sacrum. Here lies the joint. For sacral fractures, iliac fractures, dislocations of the sacroiliac joint. This is the approach. Posterior approach of the pelvic ring. Here. While fixing the anterior approach, this is the symphysis pubis. It was disrupted like this. So this Weber clamp is used to reduce it. Then you put a plate over the top here or maybe anteriorly. Just two, and you can place only 2 to 3 screws on each side. Here. Closer. This is a huge clamp called Jungbloth clamp, by which you reduce this, then you put a plate on top. This is the usual thing to do, put a plate on top These are the screws, and only this is not sufficient because a huge muscle force is acting. If there is associated sacroiliac joint is disrupted, that has to be fixed also either in that stage, the single stage, or at the later stage. Otherwise, due to instability here, this will come out in course of time. How the Ramus fractures are involved, pubic ramus. So you put a long plate, maybe if you don't have specialized plates, you put a reconstruction plates are bent like this. Then you fix the sacroiliac joint like this. This is another technique of fixing ramus, superior pubic ramus. This is sufficient. You can see that ischial ramus does not require any fixation. It's not necessary that you fix all the fractures. These are more important. You fix this fracture. This is by a percutaneous screw, percutaneous long screw, plus the sacroiliac joint. This is another example of percutaneous screw of fixing a fracture here. The screw is put from just on top of the anterior-inferior iliac spine. This is anterior-superior iliac spine, anterior-inferior iliac spine. You target this screw from here up along this, plus sacroiliac joints. Or reduction and fixation of the Ramus fractures can be done by anterior external fixation. So these pins, Sanj pins, are placed into the ilium, and then you close the gap here, putting pressure. Then you fix this rod here and fix the position of the rod with these clamps. This is the external fixator. This is reduction and fixation of sacroiliac joint dislocation. Sacroiliac joint is exposed, then is fixed by a plate. This is during the open reduction of sacroiliac joint. This is another way of reduction and fixation of sacroiliac joint dislocation. These two screws are in the ilium, this is in the sacrum. One has to be a bit anteriorly into the sacral body, not into the canal. There lies the nerve roots. These are all sacroiliac screws, are long screws, cannulated screws. That means there is a hole inside this screw. We put a guide pin, initially check the position of the guide pin through image intensifiers, CM. If it is correct, then we put the screw on top of this, over the guide pin. That creates the track. This is another one. There is a fixation. There is a sacroiliac joint disruption here, plus there is a fracture here. So this needs open reduction and fixation by two screws. Here the screws are going through the sacral bodies, not through here. Here there is nerves, caudicular roots. Another example, the ilium here is fixed by plates, and this one is fixed by one single screw. There is another sacroiliac joint disruption, open reduction, internal fixation with plate, posterior approach. This is the same posterior approach with plates. Sacral fractures. How to reduce this? Either you go for reduction of the anterior one, then that will automatically reduce the posterior one. Otherwise, it's very difficult to open up this place because there are a lot of nerve roots. So it's an indirect reduction. Then you fix it with screws. Indirect reduction by distractor and then screws. Put a distractor, then put screws. Reduction, sacral fractures, posterior exposure, clamp application, can decompress as well if needed. This is anterior fixation. This is the easy part, and the posterior fixation. This is the guide pin I was talking about. If guide pin position is perfect, then you can put a screw on top of it. This is the fixation of two sacroiliac joints. It's a good fixation. Fixation of the sacral fractures. Biomechanics of pelvic fixation, experimental data exist. In general, it seems that more points or planes of fixation provide better stability. How much stability is enough is injury dependent. Either anterior plating, superior to external fixation in internal and external rotation. Neither technique very effective at control of vertical displacement. Anterior fixation can protect posterior fixation from failure. Two-hole symphysis pubic plate is inadequate. Retrograde pubic screw higher failure rate than antegrade. Posterior fixation options include single SI screw, multiple sacroiliac screws, double plating of SI joint, transiliac plate of sacral fracture, or plate plus sacroiliac screw for sacral fracture or sacroiliac dislocation. Any of the above are more stable than single SI screw in unstable injuries. Obviously, there are some cases when the lumbar spine has to be fixed along with the pelvis, lumbopelvic fixations. In outcomes of these pelvic fractures, operative or non-operative means, pain is common, some amount of residual pain is common. Improvement occurs for at least a year in most patients. Neurologic injury, most common predictor of poor outcome. If there is associated nerve root injuries, definitely they won't heal. Sacroiliac dislocations have poor tolerance for residual displacement. So that has to be corrected and operatively fixed. Sacral fractures have more tolerance for displacement, but parameters poorly understood. Injury severity score and fracture type do not correlate with functional outcome. The conclusions are pelvic ring injury is a complex constellation of injuries. Treatment based on comprehensive understanding of potential pelvic ring instability, displacement and associated injuries. Surgical techniques for reduction and stabilization continue to evolve because this fractured pelvis surgery and fracture acetabular surgery is the new branch in orthopedics. Its life is only for about say 30 years. So newer things are coming up, probably newer and safer things will come out later. Thank you very much.